Yeah, just a few words. Words coming from an ophthalmologist that happens to be the president of the National Academy of Medicine. But I'm just an ophthalmologist, and I feel honored in being here today and congratulate academicians Suassuna, Riella, and Moura-Neto as part of the program, our young leadership of our academy. Congratulations to all of you. And I'm going to be here, mute and humble. Thank you.
All right.
Thank you, President. We should now begin. The president that probably will be on and off throughout this session. So he asked me to have the honor of conducting the meeting on his behalf. I'll start off by passing the honors to José Moura, which belongs to our Young Leader Program and has been very active not only in our academy, but also in publishing a number of books. And this is the launching of his latest effort in conjunction with Stephen Fadem, which is also already online. So, José, would you please start?
Thank you, Professor Suassuna. Thank you, Professor Rubens Dalfor. Good afternoon. It's an honor to be here today. I'd like to thank all attendees and invited speakers. This symposium officially marks the launch of the book Issues in Kidney Disease Dialysis, published a few weeks ago by a New York-based publisher. The book was edited by Stephen Fadem and I. It had the participation of 56 contributors, and more importantly, from more than 10 different countries from Latin America, Asia, Europe, Africa, North America, and Oceania. All continents were represented in some way in this book. It's a great honor to launch a book at the National Academy of Medicine, our host today. It's a bicentennial organization and one of the most prestigious institutions in Brazil. So I'd like to acknowledge the National Academy for their support. At the end of the events, I will acknowledge nominally and properly all supporters and colleagues who help make this symposium possible. We divided our symposium in two parts. The first 1 hour and a half will be shared by Dr. Miguel Riella and Dr. Stephen Fadem. This part will be in English with international speakers. We will have 4 presentations of 15 minutes each. And after that, if we have time, we'll have comments and final considerations. The second part will be starting just after the first part with no breaks. The second part will be in Portuguese only. Again, 4 presentations of 15 minutes each. I will co-chair this part together with my mentor and friend, Dr. José Suassuna. At this end of this part, we'll have comments from 2 members of the National Academy, Dr. Omar da Rosa Santos and Dr. Mauricio Yunes. Questions during the presentations can be sent through the chats, and we'll address then after each part. The lecture will be streamed simultaneously in the Facebook of the National Academy. It will also be recorded and available within a few days in the official YouTube channel of the National Academy. So all lectures are based on the book chapters, and will be presented by the authors themselves. The book has 19 chapters, and I must confess it was a daunting task to choose which one to include in the symposium. So without further ado, I'd like to invite Professor Miguel Riella and Professor Stephen Fadem to chair this first part of our events.
So good afternoon. It's a pleasure to be here. And I was asked to hand the microphone to Stephen before I call the first speaker to say a few words about this book, Stephen. Since you are the co-editor, please go ahead and share with us your thoughts about this new book. Are you there? Well, perhaps I saw him in the video earlier. There must be some problem, but let's do the following, Dr. Moura. I'll call the first speaker and I introduce, and then he will have a chance, at least, you know, at the end, to talk about the book itself. We have a 15-minute presentation on fatigue in dialysis. We need to take it seriously, by James Tattersall and Federica Picariello. I understand that Federica will be presenting. Federica has completed her PhD at King's College in London, and her thesis was on evaluating the biopsychosocial model of fatigue and end-stage renal disease, and she's currently working as a postdoctoral research associate at King's Hospital. So Federica, my pleasure to hand you over the microphone for a 15-minute presentation on this challenging topic, fatigue in dialysis.
Thank you so much, Miguel. I'm just going to share my slides.
Sure.
So that everyone can see them. Brilliant. Thank you so much for the introduction. And just to say that I'm absolutely delighted to have this opportunity to obviously present the work on behalf of all the co-authors. This was a product of our fruitful work, and it was really exciting to work on this together. So I will provide an overview of the chapter on fatigue and dialysis, and really I want to give you a taster of the type of content we cover, and hopefully at the end of this presentation give you a better understanding of what is the etiology of fatigue and also how we can better manage it amongst patients on dialysis. Just to obviously acknowledge the valuable contribution of all the co-authors. Obviously, Dr. James Tattersall got in touch with me about this chapter, and he's led the writing of this chapter. Thank you so much for that. And also the co-authors also include Dr. Hugh Rayner, Dr. Andrew Mooney, and Dr. Joseph Shokut. Dr. Joseph Shokut was my PhD supervisor. So without further ado, I'm going to jump into it right away. And if there are any questions, I'll be really happy to address them. It will be quite a whistle-stop through the talk. It's quite a lot of information. I think the first thing I really want to start with is I want to stress how fatigue is not like general tiredness. It's not like what we would feel like at the end of a long week or a long day. For people living in long-term conditions, fatigue is very disabling. And that's why I want to start with a quote to really contextualize fatigue in the experiences of patients. I've got no energy whatsoever. It's a bit like having a big, heavy weight on you. I feel like I've got a big, heavy load on me and I'm just so tired. So fatigue is really a subjective, complex, and multidimensional symptom. And the experience of fatigue really varies from person to person. So there is no unique way fatigue is experienced, similarly to pain. So providing a definition for fatigue has been actually quite challenging. Formulating a definition for fatigue has been quite challenging. A consensus that has emerged in relation to definition is that it's extreme and persistent tiredness, exhaustion that is not related to activity and is not helped by resting and recuperating. So it's that kind of extreme tiredness. It's also very important to consider that specifically in this population, so amongst dialysis patients, they may be experiencing general fatigue, which is something that they experience from day to day throughout the day. But also there is this unique fatigue that arises in response to treatment, which we refer to as post-dialysis specific fatigue. And this is very idiosyncratic to this patient population. Currently, we don't have objective measures for fatigue. And also there is no gold standard self-report instrument that we can use for fatigue. And I think what's particularly problematic in this population is that we don't have a measure that has been developed for dialysis patients, nor one that has been adopted. So often there is no measure that can both measure general fatigue and post-dialysis specific fatigue. Yet both of these elements are extremely important for the experience of fatigue for dialysis patients. And there is huge heterogeneity in how fatigue is measured. Zhu and colleagues in 2018, as part of the Standardized Outcomes in Nephrology Initiative, the SONG initiative, conducted a systematic review, and they found that across 143 studies, there were 23 different ways in which fatigue was measured. So obviously that is a massive barrier to evidence synthesis and obviously taking this work further and improving how we manage fatigue. Fatigue is a key symptom across long-term conditions, so it's not something that is just unique for dialysis patients. A recent cohort study in the Netherlands found that the prevalence of severe and chronic fatigue was high across long-term conditions. And also the likelihood of experiencing severe and chronic fatigue increases with the number of comorbidities. And we know that obviously often for kidney disease patients and specifically dialysis patients, they tend to have other comorbidities such as diabetes. So 49 to 92% of people with advanced chronic kidney disease suffer from fatigue based on systematic review evidence. Specifically in dialysis, it's the most common symptom with an estimated prevalence of 71%. So that's huge. It's 7 in 10 people who are likely experiencing fatigue. And again, to put this into context, and apologies, the numbers are obviously UK centric because of the research that I do and knowing the population in the UK specifically, but it will give you an indication of the types of numbers we're talking about. In the UK, approximately there are 30,000 patients who are receiving dialysis. And if we take that estimate, prevalence estimate of 71%, over 21,000 patients are likely experience fatigue, and for most of them, fatigue is untreated. And I'll talk about this a little bit more at the end of this talk. And another thing that is not covered in the chapter, but I want to stress is that obviously it's a key symptom for dialysis patients, but it's important to keep in mind that it doesn't necessarily just go away with a transplant. So actually severe fatigue can persist also among stable kidney transplant recipients, and there is growing evidence on this as well. The impact of fatigue is profound, both on patient-related outcomes, so quality of life and functioning. And here is a quote to kind of capture that. I won't read it. I'll let you kind of skim through it on your own. But also there is evidence growing evidence that fatigue is also associated with clinical outcomes. So for instance, we conducted a longitudinal study and we found that fatigue was associated with mortality. So a 1-point increase in fatigue was associated with 3% increase in the risk of death and a 6% reduction in the likelihood of receiving a transplant. So obviously, the impact is profound, and it's not just patient-reported outcomes. We need to consider also the impact it has on clinical outcomes. And here are just some diagrams to visually represent this relationship. This is not to say that the relationship between fatigue and clinical outcomes is likely to be direct. It's likely that actually it's through different pathways such as increased inflammation, malnutrition, depression, non-adherence, deconditioning, and other health-related behaviors. But obviously, being fatigued can actually not only impact on someone's quality of life, but actually how well they do. And this is just kind of going back to the SONG initiative, which is such a great initiative in terms of identifying what's most important to patients, caregivers, and clinicians. For dialysis, fatigue is a core outcome, and above and kind of beyond the importance of hospitalizations or dialysis-free time, which obviously, given the treatment burden in dialysis, is quite an important observation. This is also the case in peritoneal dialysis. So you can see that fatigue is a middle tier outcome. But what I want to draw your attention to is that life participation here is a core outcome, and it's likely that there is a strong relationship between fatigue and life participation. One way to understand fatigue generally across long-term conditions, but obviously specifically in this population, is through the biomedical model. According to the biomedical model, there is a direct relationship between pathophysiological processes and the experience of symptoms. And in this case, we're obviously focusing on fatigue. So things like inflammation, anemia, dialysis, and this are just a couple of examples, key examples, let's say, according to this model, lead directly to the experience of fatigue. However, this model is oversimplistic, and it really is unable to explain individual differences in the experience of fatigue. So some patients may have kind of a more severe illness profile, be more poorly controlled biologically, biochemically, yet they may experience lower levels of fatigue compared to someone who would be deemed as better controlled. Also, if we're only relying on a kind of biomedical understanding of fatigue, it really restricts the number of treatments we can consider for fatigue, because we can only consider treatments that address the pathophysiological processes. And in most cases, like dialysis, little can be done. So it's likely that patients on dialysis will experience, this trigger will be responsible for their fatigue from day to day. So another way to view fatigue is through the biopsychosocial model. So the biopsychosocial model, according to the biopsychosocial model, fatigue is a product of an interplay between biological factors, but also psychological factors and social factors. So it's much more comprehensive. And Professor Ramos Morris and her colleagues took this model further and really kind of defined what are those psychological and social factors that might be relevant for fatigue. And they developed this in multiple sclerosis, but we adopted this for kidney disease. And what's quite nice and valuable about this model is that it really differentiates between factors that are triggers, so precipitants of fatigue, and factors that are likely to, they don't trigger fatigue, but they maintain and perpetuate fatigue over time. So biological triggers, sorry, could someone put themselves on mute? Thanks. So biological triggers are obviously the ones that I've mentioned earlier, and these are just a couple of examples. They trigger the initial experience of fatigue, but subsequently it's the cognitions, emotions, behaviors, and biology that maintain and perpetuate fatigue over time. And this all happens in the socioeconomic context. So just to kind of show how this vicious cycle can work, I'll go through like a few different. So in response to, for instance, dialysis, someone may experience fatigue. And when they experience fatigue, they may perceive fatigue to be a sign of damage, things getting worse, their health deteriorating. These are quite difficult thoughts. And in response to these thoughts, it's only natural to feel anxious, fearful, helpless. And when you're experiencing such thoughts and the emotions that accompany these thoughts, it's very natural to reduce activity, especially if you think that there is damage going on and that fatigue can kind of perpetuate that damage. It's natural to reduce activity, avoid activity, rest, engage in daytime napping. But these behaviors are likely to have over long-term also biological consequences, such as deconditioning, disrupt the circadian rhythm, as well as lead to increased arousal of the nervous system. So all in all, this kind of keeps the vicious cycle going. And then on top of that, another layer is obviously the environment, the stressful events.
Por favor, desliguem o microfone, está interferindo na apresentação da doutora, por favor.
Thank you, Miguel. And the contribution of these factors will be quite unique, how they come together, and the exact content of the cognitions will be unique from person to person. So it nicely encapsulates individual differences. And also through this conceptualization, it really enhances the number of interventions we can consider. So we're not just restricted to pharmacological interventions, but we can consider also psychological interventions and also social support or socially kind of aimed interventions. Unfortunately, in the context of kidney disease generally and in dialysis specifically, very limited evidence. The evidence is scarce on the role of cognitive and behavioral factors in fatigue. This is unlike other conditions, so there is actually quite a lot of evidence in support of the importance of these factors for fatigue, in particular in cancer, multiple sclerosis, as well as rheumatoid arthritis. But we don't have the amount of evidence at the moment in kidney disease and dialysis specifically. To date, evidence has focused in dialysis specifically on the role of sociodemographic factors and illness-related factors, but their association with fatigue is generally weak and inconsistent. Patients nowadays tend to be generally well-controlled, so there is little variation in their biochemical profiles, for instance, and therefore we often don't find the association with fatigue. We conducted, so as part of the longitudinal study I mentioned earlier, we also looked at the contribution of these factors to fatigue, and we found that they play a dominant role in fatigue above and beyond sociodemographic and illness-related factors. And here are two tables that summarize the cross-sectional evidence. So just to show you that the different variables were entered in 2 steps into a regression model, and it's the beliefs in relation to fatigue, distress, and behaviors that are the strongest predictors of fatigue severity, and a similar pattern is evident for fatigue-related functional impairment. We also found that these relationships are replicated over time as well. So obviously, and this is just an example of kind of the research that I've conducted as part of the PhD, but there are a handful of studies that also kind of support, again, the importance of cognitive and behavioral factors in fatigue. So how can fatigue be treated? Well, unfortunately, there are currently no published guidelines for the management of fatigue in patients treated with dialysis, which is a huge unmet need. If 7 out of 10 patients are experiencing clinical levels of fatigue that have a massive impact on their outcomes, there is obviously an unmet need that needs to be addressed. Medical management can include specific medications that have been suggested for fatigue, such as L-carnitine. However, a review found that actually the improvements are only modest and none of the drugs can be recommended for the treatment of fatigue. Another dominant approach in how fatigue is managed is for the management of anemia. Obviously, anemia is a key symptom, a key consequence of kidney disease. And fatigue and tiredness are kind of presentations of anemia. However, even for patients whose anemia is well controlled, fatigue tends to persist, and also there is a ceiling effect of anemia management. So Johansson and colleagues in 2012 in their systematic review found that the biggest improvements in fatigue could be observed amongst patients with a partial correction of hemoglobin to 10 grams per deciliter, but there was no additional benefit of full correction to 12 grams per deciliter. So suggesting that it might work. So it's important to obviously assess anemia and manage anemia well, but it doesn't necessarily mean that automatically fatigue will improve. And last but not least, also another kind of way of medically managing fatigue is through changing dialysis modality or parameters. And there are a couple of examples here on the slide. But again, the evidence is very mixed. And what's really important to consider when it comes to changing dialysis modality or parameters is that it might increase treatment burden for patients. It might go against their preference. And also importantly, some patients may not be able to engage in, for instance, self-care that is required for home dialysis. So obviously then it restricts what can be offered for them in terms of fatigue management. There is promising evidence for exercise interventions for fatigue. This is a screenshot from a forest plot from Song and colleagues review in 2018. This is specifically exercise interventions for hemodialysis. As you can see, there was a large significant treatment effect in favor of exercise. So that's great. And we know that this is also evident in other conditions. However, this is based on only 3 trials. So the evidence is still insufficient. And what's particularly problematic is that A, we don't know exactly what types of exercise interventions are most promising for fatigue because there is huge variation in the types of interventions that are being evaluated. But also these interventions are not available in routine care and might not be suitable for all patients. So some patients may have contraindications and other disabilities that prevent them from engaging in exercise. A similar picture emerges for psychological interventions for fatigue. So we conducted a meta-analytic systematic review. Again, promising findings, moderate significant treatment effect. But most of these interventions are not actually designed to treat fatigue. So fatigue is just one of the outcomes collected, but they're not designed with that model in mind, addressing the specific factors that are actually important for fatigue. So more work needs to be done on that. And again, we need to consider patient preference. So stigma in relation to psychological treatments is a massive barrier here, as well as the treatment and symptom burden, and also the healthcare system. So psychological interventions tend to be resource heavy. And for instance, in the UK, we just wouldn't be able to implement an intensive face-to-face psychological intervention in routine care. So promising findings, it replicates well what has been observed for fatigue interventions across other conditions. But obviously, it's not currently available to patients. So there is a massive step kind of bedside to bed gap. And so just to briefly mention, we developed, based on the work we conducted, we developed a cognitive behavioral therapy intervention for fatigue specifically, so based on that model. And we found very promising evidence, as you can see from this diagram. But one of the barriers we identified that was very key and a real challenge for us to overcome as part of recruitment is the treatment burden. So as you can see from this quote, therapy does encroach on your time a bit. So I think that's probably why some people don't enter it. You don't get a lot of time as it is because of dialysis. And that's true. And that's a massive barrier that we need to overcome with behavioral approaches to fatigue. So to sum up, fatigue is best understood as a multifactorial biopsychosocial phenomenon. Precipitants of fatigue are different factors that can perpetuate fatigue over time, and this increases the types of interventions we can consider. Currently, we have no clear nor effective medical treatments for precipitants, whilst there is very promising evidence for cognitive behavioral therapy and exercise for fatigue, but these need to be designed, developed, really taking into consideration practicality and acceptability, both from the perspective of the patients, but also the perspective of the healthcare system. So a lot of promising work, but still a lot to do. Thank you so much for listening. Again, absolutely delighted to have the opportunity to talk through the chapter and give you a taster of it. And a massive thank you to the co-authors, and in particular, Dr. James Tattersall. And he's here to address any questions, and so am I.
Thank you, Federica. Fantastic. You went over 2 minutes only. So because the topics are so different, I will allow one question now. And since I don't see any questions for you on the chat, I understand, how complicated the subject is. Is very multifactorial. Given the high prevalence of depression in these patients, in some authors divide the fatigue into central and peripheral fatigue and those things. And you mentioned that the cognitive and behavioral factors are more important than the unit itself. How do you differentiate depression from a central fatigue?
That's a very good question. And actually, obviously, a lot of the time there is this kind of overlap and assumption that depression and fatigue go hand in hand, and they often do. But both from our qualitative work, it is very evident that for some patients that is the case, but for others, they experience fatigue, they do not experience depression. I think in particular, what's quite key is that we know that interventions that target depression, it doesn't mean that they're going to improve fatigue. And we know that fatigue interventions that are designed with fatigue in mind perform better than depression interventions. So there is this clear differentiation in treatment. So clearly there may be overlap in the factors, but actually mechanistically, we need to be addressing slightly different thoughts and behaviors. So for depression, you would be looking at difficult thoughts in relation to the self, the world, and others, which is not necessarily relevant to fatigue. In fatigue, we think about, we need to focus on activity and how someone perceives activity, and that is unrelated to depression. Yeah.
Good. Thank you. We move on. Is Stefan online? Stefan, would you like to call this second speaker? If not, I'll do it and you come later. The second talk is on palliative care in dialysis. And I see here that Rebecca Schmidt, an old friend, I haven't seen in many, many years. Last time I saw her, she was still at Henry Ford Hospital. She's a nephrologist and a professor of medicine at West Virginia University. Her interests include life transitions and end-of-life care for patients with kidney disease. I'd like to highlight here that she's the past president of the RPA, Renal Physicians Association, was the first woman to lead this organization. And currently she serves as Assistant Dean for Outreach and Community Engagement for West Virginia University School of Medicine. And also she serves as the physician of record for nearly 100 in-center and 20 home dialysis patients at 4 outpatient facilities. And Rebecca, my pleasure to introduce Stefan. I see you there already, but the third speaker is on you. Okay. Rebecca, where are you? Rebecca? I don't see you, Rebecca.
Yes, I'm here. I'm trying to share.
Okay, Rebecca, good. Good to see you, my friend. Long time.
Yes.
Go ahead. The podium is yours, okay?
Yes, I'm sharing my screen.
Sure.
Huh. My screen is not working here. Screen. Okay. Can you see my screen?
Not yet. Could Dr. Moura double check if you as host are allowing multiple sharing?
Yes, Rebecca Schmidt is co-host, but I'm not seeing her screen.
I think that.
Well,
I think. No. maybe Miguel, we could move forward and then come
Sounds
back.
good. Stefan, could you call upon Brenda to present the transitional care units in incident ESKD?
Sure.
Go ahead.
Sure. Can you hear me?
Yes.
Okay. Hi.
Go ahead.
And I just would like to introduce Brendan Bowman. Brendan Bowman is a very outstanding physician, and he's been at Virginia. He recently joined DaVita, and which is a very large dialysis organization that we all had the pleasure of working with. By the way, I will give a plug for DaVita that the foreword to our book was written by Jeff Gilliam, who is the Chief Medical Officer. Brendan is going to talk about a very interesting concept in dialysis called transitional care. And without further ado, I would like to introduce Brendan.
I believe Brendan Bowman did not connect this time. Maybe we can go to Megha Salani.
Dr. Rebecca Schmidt is back. Perhaps she can try again.
Rebecca, go ahead. Try to share your screen.
I'm not sure why my screen won't share.
Miguel, while we're waiting, I could say a few words about the book.
Go ahead.
Okay, well, I just want to, number one, thank Jose for the outstanding, superlative job that he did as the co-editor. And I know people who...
Okay, well, I think he's disappeared from the screen. Few connection issues right now. Steve, are your mic is off?
Rebecca, you're still trying to...
Yes, I'm going to go to a different computer here.
Right, okay.
Steve, if you're hearing, your mic is off and the connection is not very good. Perhaps you could...
We have a terrible connection. I apologize. The internet is really horrible right now.
Switch off
I think it's bad all over the city. We're having...
And just speak from... perhaps you should leave the video connection, just the audio.
Can you hear me now?
Yep. But it's speaking.
All right, I don't know how to do that. Hold on. Stop the video.
Perhaps if you just leave the audio connection on and switch off the video.
Yeah, I think we're going to lose you for this. And I'll reconnect. I'll reconnect audio.
Dr. Schmidt, you're ready to try again? And
Yes.
let's try.
Okay, let's see if we can do. Are you ready for me to try again?
Yes, go ahead.
All right.
Nice. Very good. Go ahead.
Okay, you can see it. Okay.
Yeah.
Okay. So thank you so very much for the opportunity to present our chapter. This was written by myself and my colleague Anas Diab. We're both at West Virginia University. And as you know, kidney replacement therapy sustains life for patients on dialysis, and it's intended to have benefits that outweigh the burdens and the discomforts imposed by that procedure and the complications it imposes. But for some patients, palliative care may be appropriate and implemented for patients that are contemplating withdrawal, or even when the desire to reduce one's active pursuit of a new diagnosis or other active interventions constitute similar need for more of a defined approach to palliation while continuing dialysis. And such an approach is one where priorities are the patient's comfort and the preferences for treatment is in keeping with their life goals. And the integration of palliative care into kidney replacement therapy, this includes providing supportive care for patients whether or not they wish to withdraw or continue dialysis. So embedding the option of palliative care into the current culture of dialysis care is it's been, I think, quite a challenge, and requires, it's also one that is kind of contrasts and contradicts the proactive approach we think of, and is juxtaposed against a longstanding culture of care that's supported by regulatory and payment structures. All of these may be at odds with some of the psychosocial and emotional contextual considerations of a given patient who may choose to not be the mainstream dialysis patient that we often have in our units. And as each patient's clinical context changes and the hardships associated with dialysis become less acceptable to them, some patients may come to desire a more conservative approach that's less active and less deliberate to their overall care. So palliative care, as we know, prioritizes comfort and patients' preferences for treatment that's in keeping with their own values. And it may be appropriate for patients who want to continue dialysis, but are contemplating withdrawal or just wish to de-escalate their care. So this chapter addresses the challenges of embedding the option of palliative care into the current culture of dialysis care. It presents a rationale for changing our approach, and then also gives some recommendations for integrating a palliative focus of care for those patients with dialysis-dependent kidney failure who desire a more conservative approach. So the introduction of palliation into the culture of dialysis care, has challenged the fundamental basis of kidney replacement therapy for some, because kidney replacement therapy or dialysis is an essentially proactive treatment without which death may soon ensue. And patients' clinical factors and functional factors may evolve over time, and even though the downhill trajectory for patients with ESRD often occurs abruptly and in parallel with high intensity care, not all patients wish to undergo such treatment. And this speaks to the need for early and ongoing and frequent advanced care planning and addressing issues that are meaningful to patients, and providing an approach that's very patient-centric and addresses the patient's unique clinical needs and psychosocial context. So the provider, system, and regulatory barriers are just some of the challenges that we face in trying to implement this change in culture. Now, as the patient patient population needing dialysis has basically exploded in the last couple of decades and includes a lot of patients with multiple medical issues. Rehabilitation is not always the uniform goal among all of the patients with advanced kidney failure. Some of these patients who initiate dialysis do so to avoid or forestall death, or because they hope that dialysis can support them until a certain event occurs that's important to them. So for some patients, the plans that they have or even hopes that dialysis will restore them to previous levels of function may not be realized ever, and their wishes may change over time. Commitment to continued care that might be intensive and require travel to hospitals or admission to nursing facilities may be less than a desirable option for some patients. And patients that are suffering clinical decline that may see that feel that the burdens of dialysis are intensifying, not getting better, and make the idea of rehabilitation not a realistic goal. So as dialysis transforms from something that's life-enhancing to life-prolonging, many patients and families see less and less value to continuing dialysis, and quality of life may trump death for some of these patients and their families. So addressing symptoms that are important to the patient and events specific to the dialysis process is really important, as particularly because some of the events and symptoms that occur by virtue of dialysis or the burdens of dialysis may be less and less acceptable over time. So contextual considerations are important and key to optimizing the chance that we can provide a smooth and comprehensive course for patients through the end of life and provide plans for their care that align with the specific needs of every given patient. And prioritizing a patient-centric rather than a disease or a facility-centric approach is challenging sometimes. We need to prepare patients for a poor prognosis very often, or a declining clinical status, sort of set the stage for what may occur, and have dialogue about the options of de-escalating care or even withdrawal of care, which may be appropriate, and these conversations may be helpful to patients who are struggling with both physical and mental decline and loss of independence. Many patients' situations change over time and their context changes. So it's important to have a low threshold for instituting advanced care planning type of conversations. And we all know that the provision of dialysis safely requires a very complex infrastructure with staff having specialized knowledge and a comprehensive set of processes and systems that are designed to assure patient safety. And we follow this by labs and monitoring a patient's response. And sometimes, as much as we try to prescribe these treatments individually, dialysis care is really generally focused on achieving a lot of clinical parameters that are associated with survival. And this fosters a culture of care that is designed to accommodate the needs of patients who desire aggressive, not necessarily conservative approach. So integrating palliative care into dialysis may command changes to routine paradigms that we're used to, like thrice weekly dialysis. And these things are needed to better fit the needs of patients who are suffering clinical decline or for other reasons wish to individualize their treatments. So some of the barriers to integrating palliative care into dialysis patient and for dialysis patients and their families are that many healthcare providers aren't trained in end-of-life care, and they have a difficulty estimating prognosis. They may have a moral imperative to continue life-saving efforts. They may not understand a patient's wishes. They may have unrealistic expectations themselves about prognosis, or they may just not be willing or feel ethically able to address the option. The healthcare system also, we have a lot of physician quality and performance metrics, at least in the United States, And also, there's a problem sometimes with obtaining hospice coverage. Although this may be a U.S. problem, I think a lot of our healthcare provider and our problems center on sometimes it's hard to know what is obligation versus opportunity. And do we have an obligation to put every single patient on dialysis? And maybe we don't. On the patient and family side, there's often a lack of awareness of the option to withdraw, or fear that other people are not going to accept their decision. Patients are often unrealistic about their condition and their prognosis, or they may fear that what's going to happen to their loved ones. I've had NEMBIA patients who didn't want to withdraw because their loved ones depended on their monthly check from the government, and without which they would be very, even poorer than they were. Patients don't want to withdraw sometimes because they're afraid that it signifies a lack of hope, and that would influence the caregiver in how they care for the patient. So, there are multiple clinical scenarios that can occur that are different for patients. And although the clinical course of patients in general may follow a predictable trajectory, patients have unique needs based on their individual experiences and their preferences. And the effects of dialysis and the symptom burden may differ between patients suffering with different other comorbid conditions. And importantly, the changes in their clinical course and functional status may change their wishes and their goals for care. In contrast to the patient who's thriving and actively doing well and has no reason to change course, there's the patient who wants everything done and wants all diagnostic and therapeutic efforts continued, no matter what the potential for a success, that other patients wish to pursue a palliative care approach. So, even though patients may start out one way, their life is very relative, and they may change their wishes and their goals for care. Clinical decline and other life-changing events may also result in dialysis just becoming more of a life-prolonging intervention rather than something that's life-enhancing. So a plan to continue dialysis but de-escalate certain interventions may be appropriate with or without hospice engagement for some patients who wish to continue dialysis but don't wish to pursue other type of aggressive measures. So some of the scenarios that are likely to warrant a palliative care approach for dialysis patients are patients who are declining subtly but maybe wish to continue dialysis. Then there's, of course, the patients who decline abruptly. We've all had those. And patients who started dialysis by default, or patients who started dialysis for acute kidney injury that has not abated, they may be appropriate for a palliative approach. Patients on a time-limited trial. Patients who don't wish to pursue other active medical diagnostic searches or other treatments. And then patients who are ready to withdraw or wish to de-escalate care. And some of the potential triggers for considering a change in approach to the care is for patients that have an accelerating comorbid illness, patients who are experiencing increasing frequency of the need for hospitalization, patients who are admitted to a nursing home, patients who are diagnosed with a non-renal terminal illness, significant loss of functional ability, loss of the personal drive to continue. That's a very important one and sometimes difficult to deal with for all of us. Unrelenting refractory depression, patient-specific prognoses that are poor, and then the physician, when your physician would not be surprised at the patient's death in a short period of time, the surprise question. These are all potential triggers for thinking about maybe a change in approach to a patient's care would be appropriate. And again, many of the patients in our dialysis units have, a subtle clinical deterioration in their illness. They don't have acute illness. They don't have an acute problem. Maybe it's something that's very overt and obvious, but they're dwindling, or as sometimes we say, or they're just slowly going downhill. They lose their functional abilities. They may not have acute illness, obvious. They may not have any overt processes, new comorbid conditions, but they are losing their independence, and they've slowly lost their ability to enjoy life. And basically, the changing benefit burden on balance for these patients may tip in the scale of wanting to de-escalate or withdraw care. So, essential to incorporating dialysis and palliative care into the dialysis unit are making sure that you have advanced care planning. And advanced care planning needs to be done early, often, and across the continuum of patients' clinical journey. Advanced care planning is needed to assure that we are taking into account the patient's values and preferences, and they're respected and integrated into the continuum of their disease process. Recognizing changes in the function and their functional and clinical and psychosocial factors these are factors that may impact their decision-making and goals of care about what they would like. Very important to educate our families and as well as our patients about their choices, so that they understand that withdrawal from dialysis or even de-escalating care does not mean no care. It does not mean that we're stopping care and we're abandoning them. And most important, supporting patients through the continuum of their clinical and psychosocial journey through dialysis and beyond. So some of the core components of palliative care and dialysis are these. And again, as I said, ongoing advanced care planning, it can't be overestimated in its importance. And this occurs throughout the dialysis experience and the continuum of the patient's clinical journey. Shared decision-making, we know is the pinnacle of patient care, is important throughout the patient's illness. And recognizing changing clinical and functional factors that impact our decision-making and that of the patient and the patient's goals of care. And it's important to have honest, direct dialogue with patients and their families about the goals of treatment, what can really be changed in their lives, and how the dialysis is going to impact them, how withdrawal from dialysis is going to impact them, ramifications of these decisions, and ramifications of the decision to continue dialysis as well, or de-escalate care. It's important to have anticipatory proactive symptom management. Don't wait for someone to become short of breath before you plan for dealing with these type of symptoms should a patient decide to withdraw. And tailoring our goals for palliative care with and without withdrawal from dialysis. It's very important to the patient to individualize our care for them. So in summary, recommendations for supporting these patients who do choose to de-escalate care or withdrawal is that we provide assurance that withdrawal or de-escalation does not mean termination of care or abandonment. It does not mean no care. And important to emphasize a plan for providing medical therapy that is patient-centric and individually focused, addressing our clinical, emotional, and physical symptoms with a focus on pain and in the moment suffering, offering hospice to help provide social support and clinical assistance for the family as well as the patient, and important to work with a multidisciplinary team to keep care coordinated. Plans for managing non-acute but discomforting symptoms that could occur with reductions in dialysis or withdrawal of dialysis is very important, and planning for acute symptom management to preempt the need for heat of the moment decisions. You don't want someone in the position to have to say, oh, I think I want to go back on dialysis because we didn't plan ahead for the symptoms that they may develop. And assuring emotional, spiritual, and patient and family support for the psychological pain that accompanies all of this. And again, providing symptom management for patients that do choose to withdraw or de-escalate care. I think this is the end of my presentation, but I must say that providing end-of-life care and advanced care planning is probably one of the most rewarding parts of my work and my career. And it's been an honor to care for patients on dialysis these past almost 30 years. Well, thank you very much. And I'll be happy to take a question if there's time.
Okay, Rebecca, thank you so much. I will go ahead and to pose one question and a quick answer from you. It looks like it's similar to when we Federica addressed the fatigue, the multifactorial issues, and you mentioned the potential triggers for changing care. It looks like you need a multidisciplinary, multi-professional team to care for this patient because there are so many issues involved that we as a nephrologist cannot do this. How is this palliative care team in your institution composed of?
Well, in my institution, we have a formalized palliative care service for patients that are hospitalized. For patients that are on dialysis and outpatients, I'm very strong on encouraging to utilize hospice for that extra help and the extra clinical assistance, psychosocial assistance, palliative or spiritual assistance. And then, so we do utilize the hospice for that help. If patients decide not to go on hospice, it's a little bit harder because, we do have help, and our patients decide to stay on dialysis. We utilize the social worker from the dialysis unit as well. But it's often very difficult to do that when you're not in hospital, or patients don't, at least in the US, don't wish to engage hospice. It can be very challenging and difficult, and puts a lot back on myself and my nurse practitioner or whoever's kind of in charge.
Okay, we might have some questions at the end, but thank you so much, Rebecca. Good to see you.
Good to see you.
Steve,
Thank you.
Steve, could you go ahead and introduce the third speaker?
Well, I first I apologize that the internet is working today. There's something wrong with the Comcast system, and I'm trying to get it fixed. But in the meantime, I'm using my Verizon. But I just want to first say welcome to everybody. This is one of 4 books that we recently completed. This is the one on dialysis, but we also just wrote one on chronic kidney disease with Dr. Samaya Numadou. And we also did one with Dr. Ahmed Awan on acute kidney injury, and then another one on transplantation. The good news is we already sold out of the first parts of the transplantation book, and I got a call from the publisher that they're printing some more. So that's a good sign. We would like to see this book purchased by everybody who wants to know something about how dialysis works. This is an excellent resource. And you've just heard from 2 of the authors, Dr. Picariello and Dr. Schmidt. And I can tell you, these are examples of the excellence of quality that go through this book. I start the book with a chapter on the history of dialysis care. And this has been a fun chapter to work on. There are tons of anecdotes in there that are just, I don't want to spoil it for you, but there's just a lot of fun stuff in there. One of my real heroes is a fellow named Willem Kolff. And there's a whole book written about Dr. Kolff. And I like to go through that book. The book is Inventors for Life. And I like to use that book as a resource. And so there's a lot of real interesting stuff in my chapter. And then our next speaker, Dr. Brendan Bowman, wrote a chapter on transitions in dialysis. And Dr. Bowman's chapter is very, very appealing because it allows us to take patients from chronic kidney disease all the way through to where they start dialysis and how the patient can better fit to their modality. And then that will be followed by other chapters on anemia, chronic kidney disease, and mineral bone disease, malignancy, chapters on adequacy of dialysis, KT/V. And then, as you heard, the chapter on fatigue that was highlighted by Dr. Picariello. You're going to next read about how to reduce hospitalizations and hospital readmissions. In the United States, we actually get penalized if our patients are readmitted after discharge from the hospital. And then one of the most common causes for hospitalization is heart failure. So it's only natural that a chapter on heart failure would follow that. And the next problem is AV fistula management. And Dr. Bowman has written an excellent chapter on how to assess an AV fistula from your office. The book is going to end with several varieties of dialysis, and intensive dialysis, home dialysis, hemodiafiltration, as well as peritoneal dialysis and wearable dialysis. And of course, interspersed into that is the option of palliative care that Dr. Schmidt just gave an outstanding talk on. The book is going to then end on a chapter on green dialysis, how we can do something to preserve our planet, how we can reduce our carbon footprint. The book is available on Amazon.com, and as many people know, the Amazon is a gigantic rainforest, and in America, Amazon is a rainforest of exciting literature. And we are very, very honored that Amazon is going to be selling our books. And the other thing is that Nova Science, the publisher, can give us up to a 40% discount if a group of people elect to buy the book together. In other words, if maybe 199 people all agree to buy the book together, the publisher will give us up to a 40% discount. So there are all kinds of ways of getting this book. It can either be electronic or you can actually get it in print. So I strongly recommend that you all tell everybody about the book and make sure that they buy the book on dialysis as well as the others. And so Dr. Brendan Bowman, our next speaker, I think he's online. He just left Virginia. He's going to be joining DaVita. We're very happy to have him. I've been with DaVita since it started, and I'm a medical director there, and it's an outstanding company. So I would like to now introduce Dr. Bowman.
Steve, thanks so much. I just want to say thanks to everyone for the invitation. It was a real treat to write the chapter for the book. I hope you all can hear me okay. And Steve, your chapter was great. Actually, I'm working my way, so I just want to second your comments about the text. It's been great as I work my way through the chapters. It was a lot of fun to work on it, but it's much more fun to read everyone else's work. So thanks very much for the kind introduction. Let me see if I can bring my slides up here and share with y'all. Okay, wonderful. Hopefully you're seeing the title side that says Transitional
Dr. Bowman, can you speak a bit louder, please?
Oh, sure. Sorry, I'll get a little closer to the screen. Can you hear me okay? Is that a bit better?
Better.
You're wonderful. And Becky's talk, which may not seem like it has much to do with transitional care units, though, hits the point of patient choice and decision making and educating. And so we're looking at end of life. We'll talk about the beginning of the dialysis journey here. All right. Okay, disclosures, no financial disclosures, some research stuff. And as Dr. Fadem already mentioned, I'll work with DaVita, but all of the work here will be work related to my work for the university. So here's just a quick outline. We'll try and keep everybody on time today. Why transitional care? What would you need if you're interested in that? Some operational considerations. And then the big question everyone asks, do you have any data? You talk a good game. So we'll show you a little bit of our data. And rest assured, I think things are coming. So this is data from the Brazilian Dialysis Survey, and the latest I had is 2019, which I think everyone in this audience already knows. We have more dialysis patients in the top graph, and they keep coming as our populations grow. And it's a very dangerous condition with high mortality rates. In the US, that number is a little bit different, but it's still pretty terrible. One point I want to make over here is that a lot of the care that we do, and the majority of the care we provide is in the center. Maybe we're with the patient for 12, 15 hours a week, and the rest of what we need to keep the patient safe relies on self-care, diet, medication, compliance. As we say, we ask a lot of our patients. And so transitional care might be one way we can prepare them for a very difficult journey ahead. Again, things that you already know, transitional care. Well, at the time of dialysis onset, until about 5 to 6 years after the dialysis patient is on dialysis, this is the period of the highest mortality. You can see the spike here. This is data from the USRDS. This is actually a managed care group, Kaiser Permanente data. So a group that's cared for better than many of our dialysis patients when they start. And you can see the spike in mortality right around month 2. This doesn't come down to the prevalent rate until close to a year into dialysis. So this whole period of transition over the first several months appears to be very dangerous. On the right, we're looking at the lead up to dialysis, the months before we start dialysis, about 2 months before, a month before, high cost data. And this is in our seniors and also our under 65 population. And a lot of that's driven by that index hospitalization that we see for our patients. But those spikes mirror each other. Costs and mortality are clearly very high. So if I had a small pot of money to spend on improving outcomes and care, I might want to attack the spikes where mortality is the highest and cost is the highest. And hopefully we get improvements in both of those outcomes. Well, how well do we do preparing our patients for dialysis? This is a little bit of a funky graph by age, but what we're looking at basically is the amount of pre-dialysis education segmented by age group. And the green and the blue represent basically the percent of patients that received none or no registered dialysis care. But the gray box is the group that's had pre-dialysis care and education, The gray box is the group that's had greater than a year. Well, I think anyone would say that dialysis is a very tremendous life-changing event. You probably need a lot of preparation. Not too many people receive adequate preparation. At least a third receive none, and the majority receive less than they need. And I don't think this is a US phenomenon either. So why are we so bad at this? In the US, we don't have good pre-dialysis data, but in our veterans healthcare system, our ex-military, we do have pre-dialysis data. And this is a group of several thousand veterans who were studied to say, well, how quickly do our patients drop into dialysis? We assume that we're doing a bad job because we don't have any lead time or we're not that good. Well, the truth is that this group looked at folks with fast drops in their GFR. And you can see in these two groups, they started with a low GFR and had a rapid drop. This group over here started with a high GFR, also had a rapid drop. We talk about this as acute kidney injury on CKD. This was half of the veterans cohort. In other words, half of the patients out of the veterans group had a rapid decline, which really made it difficult to prepare them for their journey into dialysis. Now, we know that there's a lot of risk equations out there now that can give us a 2 or a 5-year horizon, but we often need to start our education. If we want to start it in 6 months, we're not that good yet. And so we're going to have a cohort of patients, a sizable cohort of patients that doesn't have adequate preparation because they don't give us enough lead time. They don't drop with a lot of forewarning into dialysis. And so we're always going to need a bit of a rescue therapy for those crash patients, even if they have a nephrologist. So one solution to this, and our title is a bit misleading today, a novel approach. Well, everything is old is new again. Back in the 1970s, the early Northwest kidney centers realized that patients were not adopting home dialysis at very high rates. Now, we would say very high rates to them. They were expecting 60, 70%. Today, we would, of course, be amazed by those numbers. To combat this move towards in-center dialysis, they came up with an educational program called the Dialysis Orientation Unit. And they did exactly what you'd think they would do. They talked about diet, they talked about how to use machines, what was dialysis, they taught them about the disease. But features that made a lot of sense was they had a high teacher to learner ratio. Every nurse had only 2 patients. They were in a dedicated unit away from a typical in-center hemodialysis unit. The curriculum lasted 2 to 4 months. They specifically chose their nurses for high enthusiasm and high education. proficiency in delivering teaching to patients. They were able to bond with their patients, and no surprise, they saw a strong improvement in their home therapy adoption. They had a version of in-center self-care then, and a very small number of patients decided to move on to in-center self-care. And everyone basically went through this program that was mentally a candidate to do this. This program, as in-center self-care began to dominate in the US, this program was phased out, but it was later picked up in Canada. We'll cover some of that in a second. All right, so if I want to do something like that in my organization, what would I need? What are the elements to start a transitional care program? And remember, transitional care really is from the dialysis program's perspective. This doesn't speak to the CKD upstream preparation, but we can talk about that some other time. So what do you need? Well, of course, you need incident patients. We recommend and have had our best success with a dedicated staff for these transitional care programs. In other words, it can't be on a shift or rotation. You have to really pick out your teachers. You have to have a comprehensive teaching curriculum so that everybody is teaching from the same textbook. All right. And then you have to have goals and metrics defined so that as you go on and analyze this program, because you're going to have to make investment, you can justify the investment that you've made and be able to show your progress. So who should be in a transitional program? Well, basically all incident patients that haven't already decided to go through home training or a home modality. Why would we not put patients in a home modality through this? Well, most home training programs mirror or do a lot of this work already. So you don't need to necessarily reinvent the wheel and put them through the same thing twice. Who should not be in there? Here we suggest some exclusion. Folks that don't have a fixed address, unhoused or homeless persons, someone that's already under hospice care, someone who doesn't have the ability mentally to participate in the training, or folks with psychiatric illnesses that make it difficult. But other than that, we think about everyone's a candidate that starts dialysis. And in our program, about 60% to 2/3 of patients are able to go through there. We have 2 transitional care units in our program, and this is our dedicated team down here: physicians, social workers, RNs. We have the whole team there, but it's the same group that rotates through this each and every day. So what does a curriculum look like? Well, you have both dedicated timed tasks, and then you have continuous things that you're always working on. We're always talking about access care. We're always talking about volume status and blood pressure and educating on that with our interactions as our nurses and techs are working with the patients. Medication, counseling, adherence, these things are always happening. But we do want to be sensitive to what patients need at what point of their journey. And so in week 1, we're going to talk about an overview. We're also going to ask, what are you most worried about as you start dialysis? As we all know, many patients have a fear of dying on the dialysis machine. We need to confront those things and talk about them right up front to get them settled down, because if we can't put them in that learning frame of mind, week 2, week 3, week 4, those education things will be not very effective. Talk about finances and these things. And so we don't need to go through all of these things. But as you can see, as we move towards week 4, we're trying to get the patient to a decision point. Do I want to go to in-center dialysis, a home modality, and come up with those major decisions for the patient that wasn't well prepared for dialysis when they came in? And this is just an example of how we develop our curriculum. This is a week 3, session number 3, for example. This is who's going to be assigned to do it. This is the task that they're assigned to do. So we have our typical clinical tasks and our educational tasks. And how we manage this is a simple paper checklist. This list is printed out. We check the list and we say, okay, I did this. I took care of that session. So, and we use a nonprofit, freely available for everyone. A group called the Medical Education Institute publishes something called Kidney School, and it has good non-biased educational information, both in English and Spanish, and it has an audible version too as well. And so, you know, that gives a level-setting playbook for all of us. So what are the goals of these kind of programs? Just to reiterate, gentle medical stabilization of the patient new to dialysis, the same things we already do. in-depth education, emotional, psychological support, a welcoming, warm environment. And in non-COVID times, we typically welcome care partners, spouses, important family members who need this education as well. They're going through the journey as well. Patient navigation services. We help this small number get to their transplant appointments. We help with financial screening or insurance issues, charitable assistance. We work through all those things, get them to the surgeon for access, but we really do concierge care there, if that makes sense. And some programs, not ours necessarily, but others, also allow them to experiment with their home therapies during these first 4 weeks as well, in a very low risk managed environment, which is very safe. All right, moving on to operating a transitional care unit. These are the questions you may want to ask yourself as I'm designing this. How many incident patients in this unit per year? Will I send other patients from other units to a hub unit where we'll run our transitional care unit? What kind of constraints do I have? All the things we all know as dialysis operators in terms of budget and staff, particularly now around staffing considerations and COVID. But what do we want to do as an organization? What are our goals? Does a transitional care unit improve this? We, for example, were able to expedite transplant appointments and listings, improve home therapy numbers. That was really important to us. Your goals may be different. Could you use this shared space another way? Maybe I run incident patients in the morning, and because it's square footage I need to use, I use my acute kidney injury patients in the afternoon. Do I have patients who are on home hemodialysis or on PD that have an infection, catheters out, and we can provide a respite care center for them? So these are ways you can get creative about using that square footage. This is from a paper that Preyes Taylor, Bob Lockridge, and several other papers worked on. You can kind of shoehorn a transitional care unit in a number of ways. It can be as simple as saving a couple of your existing chairs, or one if you have a small census, for an incident patient, a Monday, Wednesday, Friday. That's the simplest way to get started, all the way up to having your own physical plant, your own facility and square footage. So there's a number of ways to do that, and you may want to integrate it with your home training team, so it's near your home therapies unit. So there's lots of ways to do this. Key decisions: where would I put this unit? Should I run 3 days, 4 days, or 5 days a week? Pretty significant staffing. And then decide on those metrics. Will I look at patient engagement before and after, education surveys? Will I see reduced readmissions, reduced admissions, as Dr. Fadem was mentioning? That's a key component in the chapter of the textbook. Or will I see increased home dialysis adoption? That's pretty exciting. So again, the question, do we have data? This is some historic data. As the original Northwest Kidney Center's dialysis orientation sunsetted in the 80s, our neighbors to the north in Canada really embraced this idea of a unit for patients crash starting, and they've had dialysis orientation units in some cases since the early 2000s. And the numbers are pretty remarkable in their heads. This is an abstract from the Canadian Society of Nephrology. But in the crash start group, 50% of patients chose a home therapy versus 5% the folks that went through usual care. Our numbers weren't that good, but that's really impressive. So a little bit about our program. We have hubs in Charlottesville and Lynchburg, and other new start patients at our satellite units will come through those programs. As I mentioned, we have a 4-week curriculum that covers all of these things. And at the end, we refer to the patient finishing their education there as a transitional start unit, is what we call it, but we call them a TSU graduate. And they can go to home, peritoneal, or in-center care. And we now offer in-center self-care. That's new for us in the last year or two. This is data that goes through about 2019. We had 81 new start patients. These were not patients that already picked home dialysis, patients who may have seen a nephrologist. Typically, we saw about 5% of patients go to home dialysis after they started in-center as a crash start. Here we saw 25 out of 81 patients go. And ultimately, what we worked out with is about 30% of patients chose home. That's about a 6-fold improvement over what we previously had seen. We knew from surveys 50 to 60% of patients wanted to go home, but had barriers to going home that made it difficult. So we thought this was a pretty remarkable number for us. And of course, our program was simultaneously seeing another group of patients start on home dialysis out of the gate. An interesting finding, when we ran 4 days a week, Monday, Tuesday, Thursday, Friday, is that patients in the Transitional Care Unit program had a 32% lower weight gain over the weekend than patients in a traditional Monday, Wednesday, Friday only group. Same Saturday, Sunday break, but 32% difference in fluid gains down there. Lots of theories as to why that could be. Now, these patients have a lot of residual renal function and made plenty of urine. If you look at in-center dialysis patients that are prevalent, the fluid loss when you run Monday, Tuesday, Thursday, Friday over the same break, 50% fluid reduction in their weight gains when you run an extra day over the long weekend. So that allowed us to run just on the weekdays without having weekend staff. So just to wrap up, a TCU program really isn't a standalone idea. What it does is it takes patient education, patient engagement, patient choice, patient empowerment. It takes all of these things and serves as a hub, a central location where you can do many quality initiative ones. If you're an academic program, you can start studies on incident patients and involve them right away. It's relatively low in cost, depending how you do it. You can save a couple of your traditional dialysis machines, run Monday, Wednesday, Friday, and because you don't have a lot of incident patients coming through at any one moment, it's only a little bit of extra time on the IDT team, the interdisciplinary team. And targeting the incident dialysis period, I think, is the greatest bang for our buck, if you will, the greatest return on investment with limited resources in a dialysis place. Now, it will not and should not replace really high quality pre-dialysis care. That needs to continue to get better as best we can. But there will always be 20, 30, 40% of patients that are overwhelmed by their start in dialysis and need a gentle, stabilizing start to dialysis. And we think this is a good approach. It's worked well for us. Okay, that's all I had, and hopefully I finished on time. Thanks so much.
Thank you, Brendan. I believe Professor Suassuna or Professor Miguel Riella, it was a terrific presentation.
Well, thanks very much. I know we're short on time, and I certainly want to see Dr. Salani's talk too. So,
is Miguel online? Otherwise, we just follow on. Dr. Fadem, are you online?